All right. Well, good afternoon, everyone. My name is Kimberly Randall. If we haven't met, I'm with the Lister Hill Center for Health Policy. I'm very excited to welcome everyone today to today's seminar with Dr. Lea Yerby. For the 2023 calendar year, the Lister Hill Center is focusing on the role of civic engagement in health policy and how public health officials, students, and researchers can continue to get involved in understanding and taking action on the problems that we see every day. Before we introduce our speaker for today, I do want to go over a few housekeeping items. For our virtual audience, please utilize the Q&A function to ask any questions, as there will be a brief discussion period at the end of the seminar. Additionally, the seminar will be recorded and posted onto our website in the coming week for future viewing. If you enjoy this presentation and you want to continue to learn more about the topic of civic engagement, I invite you to join us on Wednesday, April 5th, for our next presentation featuring Jane Adams. Jane is the Legislative Campaign Director for the American Cancer Society and currently leading a coalition of 140 organizations in the state of Alabama working toward the expansion of Medicaid. That event will take place at Alumni House, and while there is no cost to attend, registration is limited and can be found on our website or the UAB campus event calendar. And now it is my absolute honor to introduce our speaker for today. Dr. Yerby is an associate professor in the Department of Community Medicine and Population Health at the University of Alabama College of Community Health Sciences, focusing on health disparities in rural populations and access to screening and intervention for autism spectrum disorders and Medicaid innovation. She received her bachelor's degree in biology from Belmont University in Nashville, Tennessee, her master's degree in human environmental sciences from the University of Alabama, and her PhD in education and health promotion from a joint program of the University of Alabama and here at the University of Alabama at Birmingham. She has spent more than a decade as a leader in the Alabama HIV/AIDS service and policy community and was named an advanced health promotion policy expert by the Society of Public Health Education and was selected to participate in the National Institute of Minority Health and Health Disparities Translational Health Disparities course. She's also a member of the Society of Teachers of Family Medicine and the Society for Public Health Education. So please join me in welcoming Dr. Lea Yerby.
I'm so excited to be here. I did take classes in this building in my PhD program, so it's fun to be here. And I'm also an affiliate faculty at UAB School of Medicine because I do teach medical students every day as well. And teach community medicine and the leadership in community and population medicine as part of our primary care track in Tuscaloosa. So, but I don't get to be here on this campus. Oh, well, I'm going to be here next week too, though. What about social determinants? But I picked this slide as our front today because it is entering cherry blossom season and we're getting close. We're getting near spring. And since we're talking about DC today, I realize even in my introduction, there's already things that I would like to say that I've forgotten. So that I don't have in here. There's so many things that I could say today, hopefully, but then we're going to get some takeaways that are practical and informational for everyone. There we go. Sorry. I do have a PhD canvas now. So a little bit else about me other than what we put on websites. I am a dog mom, to be very. And this is she is almost 16, so that's a good journey. I am a daughter to my parents and very much an active caregiver as well these days. So I feel like a lot of my other women in academia are experiencing that. And so that's something I'm interested also in as well these days. I am a godmother to 7 and an aunt to most of these people because my sister is older than me. They married a widower older than her that had 7 children. So right now I have 8 great nieces and nephews, and the 9th one is on the way. So, and then I also am a farmer and have the farm that my mom grew up on, and these are some of my zinnias there. A dream is to be a flower farmer, and then also research, right? So today's plan is to tell some stories about my experiences, then give some examples of translating research into policy in the real world. There's 1,000 ways to do this. I'm just going to go through some of the ways that it has just played out in my life and career thus far, and then pose some questions and hopefully have some conversation. Okay, so let's start at the very beginning. This is me at 27 years old, the very first time I was in the US Capitol. Granted, I had already been a staffer for at least a week. We made it into the Capitol for the first time, but this is when it happened. I still am amazed by this building. And I didn't know it was that beautiful inside. So it is, I don't have any delusions about DC, but that building is magical to me. I had a very unusual path to policy. I say that more to let people know that there's no right way or no cookie cutter way. I think we know that increasingly. But a little bit of how I got there, which was a bit of a fluke, if you will. It was either some divine conspiracy or a fluke, one or the other. So I was a PhD student that was kind of homeless because my department fell apart. And I had been trying to get a committee together and had been, the graduate students that we had run our program for about a year already. And I was just trying to figure out what was next. And I had built a committee of lots of other people from other colleges, but my own department didn't have any faculty. So I was just going to be hanging out for another year, paying tuition, trying to stay in the program. Was probably going to be an athletics tutor, you know, trying to be like, okay, what am I supposed to do right now in this place where I'm stuck? What I was thinking about doing when I graduated was the CDC Epidemiological Intelligence Service. I was really obsessed with epi. I always thought I was going to be in international health. So that was kind of what I was thinking is probably next steps. My dissertation was on West Nile. Like I had originally wanted to be a rural medicine physician, but then wound up going a public health route instead. So that's kind of where I was. Because I am originally from Kennedy, Alabama, which is population 420. We have a caution light. We are really proud of it. There's a hairdresser and a gas station. So I do have that rural health background. But I was not coming into it in the way that a lot of people might expect or think when they go into an Alabama congressional office. And then I got a phone call from a friend of mine who had gone back and forth between being a congressional staffer and a public kindergarten teacher, public school kindergarten teacher in various places. So her and her husband had just moved back to DC. She had taken a legislative assistant position in education and healthcare in the Sessions office. And they just called and said, hey, the person that's supposed to fill this job just backed out the last minute. What do you think? And I just knew that I was a person that didn't know what I was going to do in that moment. I knew that I was in a person holding pattern with my life. So I was like, well, let's find out about this. And I should say that every time I had ever been like interested in politics along the way, like throughout high school or undergrad, I would like get so far into it because it seemed like really appealing as a way to make an impact. But then I would get so like icked out by politics, I would quit. I still go through that cycle on like a regular basis. If you're that person, that's okay. We don't all have to fit in a perfect box, right? So then again, I was an unusual fit for policy, but again, there's no right way. I say this just in case anyone in here is into Enneagram. Just as an example, I know that it's trendy for some people. I'm an Enneagram 9. Okay. And the reason why that is important for this conversation is that my main driving force in my life is to avoid conflict. So, yet I teach policy for a living. So these things don't really make sense or go together. But that does mean that I'm really into problem solving for groups of people, right? That it does mean that I'm really about looking at what brings people together. I went into this incredibly naive about partisan politics. And I think that was, I mean, I learned an awful lot. But that's an important thing here. And but these things may be a good fit for tying everything together. But like my main driver in life is like keeping a room at peace, making sure everybody's okay. Right. So to throw that in then as into DC, a little bit of a mess. But this is like this little meme of that of like kind of never knowing peace themselves because they are constantly at war within their own intensity for the sake of other people's peace. And then being the peacemaker in their families, friend groups, professional settings, because their calm demeanor and abilities make everyone feel valued and seen and heard in all perspectives. Right. This is basically the last person that needs to move to DC, but makes me suited well for research and policy. Okay, so my fellowship was not through a foundation like most fellowships, and like all the other fellows that I was with at the Hill. So first of all, an important note is that fellows are not supposed to work on legislation. They're just supposed to be researchers. Your legislative assistants, your LCs, your legislative consultant. That word just left me because I'm standing in front of people. They are the ones, your legislative directors, your chiefs of staff. They are all there purely to do partisan politics. Fellows are not supposed to. I did wind up working on some legislation because of my background in the particular year that it was, and we'll talk about that. What it was that Trent Lott decided he wanted a health policy fellow. So he got one. So Mississippi had a fellow. So Sessions was like, Mississippi's got a fellow, I want a fellow. So he just made up his own fellowship. So I had the opportunity to take this position because a nursing faculty from Stanford had already taken it and then declined literally the day before she was to start, which is how I had this opportunity. What I was commissioned with was to attend the help committee meetings and hearings and give research insight into that. Right, so I wasn't supposed to say, here's what a Republican would do, here's what a Democrat would do, and say, hey, this is what is real life or what research says. And this is why you run into a lot of fellows that are housed in congressional offices that are attached to committees in their specialty area. So at the same time that I was there on the help committee, there was an ED physician, there was a cardiac surgeon, that were taking like mid-career fellowship opportunities.
Excuse me, but for those who may not know, HELP stands for.
I am so sorry. That's so important. And that's the number one thing that I dislike about DC is acronyms. And then I have done this. HELP is the Health, Education, Labor, and Pensions Committee. So yes, the Senate decides that all of those things are one committee. And so all kinds of things fall under there, though maybe not what you would expect. Medicare and Medicaid fall under finance in the Senate. So we would get tons of calls of people yelling at us about Medicare. No, but we can't do anything. We're like, yes, you can. Be like, no, actually, that's like literally not under our authority, but okay. So I was to attend these, which we'll see in a second, wound up being a very interesting year. Also, some important notes. This was 2005, 2006 when I was there. So this is older information and the world is very different. But it was a really interesting time to be on that committee because you had Senator Frist as majority leader, who was a cardiovascular surgeon. and who had built out his own whole health team just because of his interests. And it's when Enzi was chair of health, and a lot of his committee staff had actually come from the CDC. And then it was also Alexander, Burr, and then of course Patty Murray and Ted Kennedy and Hillary Clinton. So in health policy, Clinton and especially Kennedy health policy staffers are legendary. So I did have the opportunity to work with them on a daily basis. I also had the opportunity to ride the elevator with Ted Kennedy's dogs on a daily basis, which was kind of a highlight. But that is probably my favorite thing. Which, just a side note, some offices are dog friendly on the Hill. Ours was not, but a lot of them were. Clearly Kennedy's was a dog office. So everyone, they all came every day. So my other task then was to take health meetings with constituents, along with the LA, who would normally do that, or and sometimes there would be so many meetings in one day, then we would definitely split those. But taking constituent meetings on health topics, creating a comprehensive review of the status of health in Alabama. This is basically just like, go give me a full comprehensive report of the health of the state. Go. All right, so a lot of that of me in a rental car, lots of various places. I have toured all of our critical access hospitals and things like that, right? And then to be a rural health specialist, and which I did come in with that background and that interest, but real quick they just started telling everyone, oh, we got ourselves a rural health specialist. So that meant I became a rural health specialist really quickly, if I was not one already. Okay, so again, I heard about this position, I interviewed for it, I accepted it and flew to DC to find housing all within a 24-hour period. No, I did not sleep that day, and I was an insane person on the airplane. I did miss my flight that day because I couldn't remember time zones because I was so freaked out at what was happening in my life. But I got there. And then I moved to DC the day before Hurricane Katrina. And then I started my job the day after. And of course, we were a hurricane state, clearly. And we were in that unique position of being both a very affected state, but not being as affected as the others. So also contributing a lot to Mississippi and Louisiana the best that we could, while also trying to take care of our own. So that was just, you know, like there's never going to be like really words for that. For starting your job at the Capitol, you're watching New Orleans flood on the television, you're getting all these phone calls, and they were just running around like mad. I had gotten a badge. That is what I had, literally. And my new boss, our legislative director, kept telling me to call the White House. I was just like, I'm like, okay. And then finally, after they had asked me like the third time, like, and they were so upset, why haven't you called the White House yet? And I was like, how does one call the White House? Like, how do you do that? I don't, and they're like, okay. Then they realize I don't have the phone book. And they give me the phone book that has the secret numbers in it. And I call the White House, right? I do not have those, so they can away from me. I'm sorry. So that was literally my first day of my job. 6 months later, once it was calmer, my boss to me went, wait, did you ever get any kind of training? I was like, no, that did not happen. So next with that, so that immediately meant that I was, again, coming from where I was coming from, a doctoral student just wanting to finish her dissertation and go do public health in the world. Was suddenly in the emergency meetings for a Katrina response. So I'm in Senator Frist's office, and I'm supposed to be helping leadership determine what we're supposed to do with Medicaid. So the biggest issue then, I know that this is a really long time ago for a lot of you. So was what do we do with the fact that Medicaid can't go across state lines and everyone has to disperse because they can't live there, right? They don't have homes. And so you know, so many people had been displaced to Houston, Alabama, all of this, right? At that time, I did not actually know the difference between Medicaid and Medicare, being perfectly honest, right? Because another thing I'll bring up is I did health ed and health promotion program and focus on public health way before the Affordable Care Act. And so a lot of things have changed since then. It didn't have the same kind of education or focus on some of the policy elements that I think that we get now. So I did not know that representing a conservative office meant that the last thing I was supposed to say was, yes, please, let's expand Medicaid now. And let's cross state lines and still get Medicaid in another state, right? And so they're looking at me, and I was sitting there and I was like, oh, like sheer panic, basically, just like, okay, I'm in this place. And I remember I just looked at them because they were like, so you really think that we should take this approach? And I was like, all I know is I've got a lot of diabetics that are dying without insulin because they don't have a home, right? Like, which was reality. That was what my voicemail was full of. And I didn't know anything about what we were actually talking about, but I knew that, and that's what I said. And thankfully, people actually kind of listened to that. So it was very much like, I don't know what I'm doing, but I'm here, and I'm going to represent what I can. So it was a trial by fire, and I learned a lot of things very quickly. Again, here we see I have and policy. I just kept thinking over and over of how I had written so many comps, questions, and answers, and it included the social ecological model, but nobody ever actually told me what policy was. We would just be like interpersonal, institutions, community, and policy. Like, it was always like, and policy. No one went past that, I felt like, in my training. And then now as a policy fellow, and I felt like I did not even know what the word meant. And so I just started, like, it was my icebreaker question, like talking to the people I was working with, like, so what does policy mean to you? Like, what do you think you're doing here in your job? Kind of thing, because I was very lost. Which I realize now, policy means whatever you need it to mean in that moment. Because what can be separated from our health, right? But at that time, I also very much felt like it was the word Smurf. If you happen to be a child in the 80s, for Smurf just means anything that you need it to mean at that moment. That is kind of what I took the word policy to become. And then I kept trying to communicate to them when I was being asked very specific Medicare claims questions, and being expected to know what any of it meant. I was kept saying, I do health, not healthcare. And no one could remotely, like, people would just like walk away from me. And after I'd been there for some time, again, my boss said to me, you say that, but that's not, there's no difference. She's like, stop saying that. That makes you sound stupid, basically. I was like, okay. But it was that healthcare is health, and really claims are health in DC, right? Like, we have to understand or concede that. Again, some things are definitely different now than they were then. I think the Affordable Care Act kind of educated the country and also had more people become aware of what certain words meant and what health policy meant, and maybe how that trickled into their own life. I feel like there's a much more consciousness after that than there was before. But this is what I was experiencing then. Also, people, every time I introduced myself and said what my job was, everyone would say, "Oh, I'm so sorry." And I was so offended. But I didn't realize that being a health, working on health policy, being a health LA, anything like that, is just considered to be the most difficult, challenging thing to do in that town. So everyone on all the other committees would just be like, "Oh." And I did not know that it's the position with the most burnout and the most turnover. By the end, I really understood that. Particularly in the spring when you have more constituent visits and more group visits from all the conferences that kick up, you might have, again, 25 meetings a day that are just back to back of people bringing very intense personal stories and asking you what you're going to do about it. Literally bringing children with disabilities to meet with you and asking you what you're going to do about it. So it is not for the faint of heart. So by the end, I understood that a little bit better. At the beginning, I was really offended. That was, again, a little bit naive and super eager. And so I'm just glad to have the opportunity. So again, I had mentioned that fellows aren't really supposed to work on legislation, but because of Katrina in particular, that year saw a lot of public health related legislation. So the Pandemic and All Hazards Preparedness Act, which in committee we called Big Papa, was one of those. So some items that included was putting emergency health response back under HHS and taking it away from FEMA, which had been part of the nightmare in Hurricane Katrina. It included creating the Assistant Secretary for Health and Preparedness. It created the National Emergency Management System, or NEMS, that impacts much of our emergency response and ambulance response across the country on a daily basis, and where we get all the data for that now. And it also created the National Pandemic Response Plan that got completely dismantled by the time we needed it. Y'all might have read some about some of that. So that's its own whole story. I was the first deputy director of the UA COVID response team because I had that experience of helping write the national response. But man, was it heartbreaking to realize all this work that you had the opportunity to be a part of so long ago just did not even exist anymore. I also got the opportunity to be part of the Ryan White reauthorization. And for those of you that don't know, Ryan White is the legislation that is the primary funding for persons living with HIV and AIDS. And it's the only illness with its own legislation to that degree. And out of curiosity, show of hands, how many in this room know who Ryan White is? Okay. I am going to pause. I know that I probably don't, and we're probably running out of time, but this is something that's really important to me, that is something that's kind of missing in the education and consciousness of anyone younger than me sometimes these days. So Ryan White was around 12 years old when he contracted HIV because he had hemophilia. And so at that time in our country, it was a pivotal moment, because before that, HIV had definitely been, white gay man disease. Now we had a 12-year-old that had it, and we had a really vocal advocate mom. And he was not allowed to go to school anymore. I was probably 10 and watching his story play out in the media. And that might be even part of why I really did pursue public health, right? To see that story and see that this mom advocating for her son. And then the response, like his funeral was televised and Michael Jackson was there, and so Elton John was there, all of this is kind of burned into, like I did my book report on him. These kinds of things are like burned into the memories and the consciousness of a certain age group of people. But that is why the healthcare legislation is named after him. Did have the opportunity to meet his mom one day in Montgomery when we were doing some of our HIV policy. And another reason this is important was that was the first year that there was a real focus on the money following the disease. Whereas majority of the funding always went to the cities where HIV was first diagnosed and where the outbreaks originally took place. But as we know here in Birmingham, that now it is very much a disease in the Southeast. That became the epicenter, but none of the funding was following where the disease was. So that was the first year that any of that changed, for the funding to fight the disease to follow where the people were that had it, and it to be attached to case numbers instead of cumulative case numbers, which kept getting all the money to New York, San Francisco. So that was a very intense political battle because New York and California don't exactly want to give up the money that they have. But that was a really interesting kind of social justice policy movement to be a part of that I could talk about all day. Also, I was tasked with figuring out ambulance reimbursement because nobody in all of Congress understood ambulance reimbursement, basically. So that was fun. It is incredibly complicated. And it is really kind of a miracle that any of us have an ambulance when we call one. So never take one for granted would be what I would say for that. And it's a really complicated structure, and it's really fragile if anyone has interest in that. It's a really interesting policy area. Okay. So every single day was like drinking from a fire hose. I learned more every day than I've ever learned any other time in my life. Just having constant experiences. And I was definitely not an intern, right? People that had these like fun stories of when they were in DC one summer was not my experience. I was an adult, I was a professional, I was expected to answer my BlackBerry at 3 a.m., so I didn't have these fascinating stories, but not like a lot of these great fun stories when people are like, oh yeah, my niece went to DC, she had the best time, she was partied a lot. That wasn't what I experienced. I wanted to finish my dissertation, which had still not happened. I was still paying tuition hours because I was trying to figure out how to stay in school and be able to finish my dissertation. So but I had a lot of opportunities. I thought I had to stay there because there were opportunities so few people got. But then I was having massive issues with fever blisters. I had an ulcer, and I went to the doctor, and this very sweet maternal physician took my hands and just looked at me and said, "Go home. You don't belong." And she was like, "You are a good person. Please go home." So we do need good people in DC, right? But it wasn't a great long-term fit for me there. And as soon as I came home, I didn't fit in either world anymore, right? Like as soon as you're not on the hill, you're an outsider. But then I was in academia trying to get them to understand what we needed from them. What is needed to be able to make good policy. Okay, so then I transitioned into a faculty position after I completed my dissertation. That did finally happen. In CCHS at UA, and my job was really just to focus on the healthcare projects in Alabama that the college wanted. So I did not have a typical faculty position, and I don't necessarily recommend that because it took me 10 years to promote, but it also meant then that I had just kind of done everything. I was supposed to be the connector that did what was needed, and that brought people together to fulfill whatever projects and aims that we had. So my political relationships definitely changed pretty immediately, but my community relationships strengthened. So those times when I was just driving around middle of nowhere, Alabama, those times where I was taking 20 constituent meetings a day, that is when that became really important. And those things have remained. So I still work with people every day that I met as a fellow. Okay, so now I'm more to maybe some of the practical takeaways for y'all. I'm sorry, I didn't realize it's 12:38. So research that leads to policy change. It's research that provides you numbers and information that bring influence. It's research that can answer policymakers' questions. We might not always like their questions. We might, because we're researchers, right? We have our own agenda. We want to go answer this question. Well, it might not be the one that our society or leadership needs answered at that moment to do what they need to do next. Which is part of that tension of being a researcher in this space, I think. You need to do research that provides talking points. Whether we like it or not, it needs to fill a speech, it needs to fill a media clip. We need those kinds of things. Our research is too slow for everybody but us. You know, they always said they had it yesterday and they don't understand why we can't do it more quickly. They don't understand cleaning data and making sure it's good at all. Okay. It's rarely, the kind of research that leads to policy is rarely sought out or read in academic ways. So we can't just publish it and put it on our CV. We have to go put it somewhere else or nobody will find it. And they certainly won't use it or read it, right? We need to focus on cost savings and numbers, no matter how we might feel about it, right? We've got to tie into that, be able to start the conversation and bring the meaning that they need. We don't always like how practical it has to be, but you can still find ways for it to be innovative, right? And it doesn't always set you up for promotion at all, right? You build a lot of relationships and you do a lot of work that that might not take you very far with your dean, or might not take you very far with your APT committee. So that is another place where this tension always is. I mean, that's getting better than it was, but you know, I've done multiple Medicaid evaluations that they kind of wish I hadn't done, you know?
You spend a little bit on, so if research needs to change, is really great and read because of ways, it's not just the papers, how to use it, it's just like the news articles, is it the short briefs? What is the format?
Yes, short briefs, news articles, or getting it to other people that they'll listen to. That I think that is part of it as well. Maybe sometimes books, like they want the information, but they just want it in bullet points when they need it. Or they want, they might want another community leader they already have a relationship with to hand it to them. They, I don't know, that's a really great question that you just asked. I guess she's asking, if not in academic journals, clear. So I think that goes back into like, dissemination of are we disseminating it to our local leaders and our community partners? Because a senator's going to listen to your community partner before they're going to listen to you. Most likely. Not always the case. So these are several real life examples that I have that I'm just going to try to go through quickly. So one way to do this is state policy working groups. I was on the Alabama HIV policy group for about 10 years. That's one of the things that I did after I came back. And that was primarily successful through having a really accessible talking points. At that time, we were particularly working on the AIDS drug assistance program and trying to eliminate that waiting list and trying to get our state legislatures to realize how important it was to make their federal match for that. And one of the things that resonated with them the most or got us the furthest was being able to tell them how much one day of uncompensated care costs for somebody with HIV in the hospital. So if you have your hospital administrator saying, yes, I lost $100,000 in uncompensated HIV care last month, then that they listened to. Also, a lot of our state legislators did not realize that they really had cases in their counties. So just letting them know that it actually was something in their county, they actually really listened to, even in our states. And we also, if any of y'all have worked with Kathy Hires, you know that she's literally like the legend. The opportunity to work with her has been, I mean, it permanently changed my life, right? Like I would just gush. But so she is a leader in HIV in the nation, but at least in the past that we would take about 250 people living with HIV to Montgomery every year and let them go meet with their legislators themselves, give them some advocacy training. And that was incredibly impactful. And so while we might assume that ADAP might have been something that was supported in our state, it actually was. But that largely came down to a relationship, having the bullet points with the money and the numbers, but then also having someone come tell their story about how they get to live their life and go to work because they have medications. They're participated in the first telehealth statewide group that has brought about the Southeastern Telehealth Resource Center that was started out of the governor's office. I think that was Riley though. I'm going to skip and come back to that. When I was talking about HIV, a special note. So I became a board member at West Alabama AIDS Outreach that is now 5 Horizons. And I was on that board for 10 years. I was president of it for about 3 or 4 years. And that was a place where I chose not to do research. And I'm not saying that is necessarily the right way to do it, but I felt like I was in a place where that was what was important at that time because I had gained the trust of our consumers and clients. And so many people were coming from other states that wanted to do research with our population that it became more of my job to vet the people that wanted to have access to them and kind of protect them than for me to do research with them myself. So other colleagues in my department did. I'm not saying you have to do it that way, but in that particular position with such a vulnerable population that actually I had real relationships with, we did have Harvard come study us for a while. Like you were mentioning how that happens. So sometimes people from Duke come to Selma, right? We were experiencing that. So in that role, I actually chose not to do HIV research. Okay, so another great way to participate in making research translate into policy is by working with or serving on nonprofit boards. Now, they cannot be political, but they can advocate and educate They can invite leaders for visits to their agency. They definitely go meet with legislators. So what you can't do as a professor or faculty member of the University of Alabama at Birmingham, you can do as a nonprofit board member. Like you can go be yourself in another path and you can present your research there. Or you can do research that contributes to that mission and builds their talking points. You can always be a resource to decision makers. Always let them know you're available and just actually be available in that. It might not be convenient when they need to talk to you. But they do begin to lean on people that they trust and that are available. Being a part of a nonprofit board then allows you to share your work and other than being a professor. You can then also guide local funds, either how your in particular agency is spending, or also we were talking about this as well briefly, how your city leaders distribute funds. So as board president of WAO, it meant that I wrote a grant to the mayor of Tuscaloosa every year for them to send funds to us for certain things. And then, so just the examples of the boards that I've been on and experienced this with so far, the WAO 5 Horizons, the Tuscaloosa Campaign Prevent Teen Pregnancy, it doesn't exist anymore, but it was the only other one in the state other than the Alabama campaign. Family Counseling Services, I've just joined the Tuscaloosa County YMCA. And then the United Way of West Alabama VAT team. This is also a really interesting way to get involved with your community. Has anyone ever done this before? Know what I'm talking about? Okay. Would you agree with that? So what that is every year your local United Way agencies write their grant to the United Way, the local United Way, asking for their funds for their year for whatever they're doing. You can be one of the people that reviews those grants and does those site visits and determine where that local funding goes and what projects it supports. And you also get to give them direct feedback on what you would like to see from that agency. So that is definitely another way to impact that locally. Okay, we talked about this a little bit, getting in front of people other than academics, right? So speaking to professional groups outside of academia, maybe local business leaders, maybe professional conferences. So the one thing that has really worked for us with autism has been speaking to the AAFP, which is the Alabama Academy of Family Practitioners, just on what like their basic QI ought to be, or what screening is supposed to be, because they did not know that yet. Like what just is evidence-based care. And that really led to a chain of events. That meeting led to Dr. Moon, the former chief medical officer for Medicaid, to asking us to help him research what the cost really would be and what Medicaid should be covering for children with autism. Like that, just getting to talk to the family docs led to that request, which ultimately led to through lots of efforts and lots of things. We know Medicaid was really slow to do this and actually kind of had to be forced to do it. But they do now. It led to legislation in 2017 that does now all cover autism services. Now that's a really complicated other separate lecture. But and it did also spur some QI initiatives. So like the Alabama Academy of Pediatrics got mad that we did that. So they worked on their QI thing to try to get people to start screening for autism. So we actually were not screening at all in our state, pretty much before then, outside of like this academic center. That's a really rushed synopsis of that, but that's kind of how that really happened, or that piece of that happened in my experience. Lots of other people were also doing other things. and community health centers, that they have an annual conference that could be a really great place to actually get to know your actual people doing a lot of the work. And find ways to directly put policy or innovation into an underserved community. I don't think I used the best language when I was just talking about that autism piece, but sometimes you get the opportunity to actually write bill language yourself, either as a part of an appropriation, or if UAB puts forth what their priority is for the year, and that's your specialty area, you might get to actually write language that would be included. That doesn't always go anywhere, but then you at least you can put your research into the Federal Register in that way. And again, that comes to always being available when you make those relationships and become someone that staffers would trust. You can also testify at committee meetings and hearings. Okay, you can do evaluations of programs and policies. So these are 3 Medicaid waivers that I have contracted to work on and evaluations for. Again, this is one of the things that's a lot of work and can be frustrating work, and it's not necessarily stuff that you get promoted on, but it's important and a direct way to implement policy, right? So this ACHN, this was all of managed care for the state of Alabama, right? You get that data and you're supposed to tell them if they're doing it right. Right, so if you're gonna, and then you have to submit that report to CMS, and it has to go on a public website. So even if that's not a publication, that's a lot of really important work in a way to move policy forward. Another colleague that I have does a lot of CDC evaluation that gives opportunities to create policy. Claims analysis. It's the clearest way to show the impact of policy on costs. One that we've done recently was a medical home for foster children that reduces expenditures. This is our foster care patient-centered medical home clinic within our PEDS clinic. We were able to show that it had direct impacts on reducing length of hospital stay and pharmaceutical costs for those children. So those are the kinds of things that policy leaders are going to more quickly respond to sometimes. We're doing an ongoing Medicaid autism claims analysis, looking at what Medicaid claims looks like before and after that legislation was passed, and to see what we can learn from it. Claims without a medical record don't always tell you a whole lot, but it's a start. You can work with municipalities and communities. So I've done a HRSA EMS grant in Macon County with their local leadership, and they actually did not have an ambulance for their county. So we were trying to get them some more 911 access. I'm currently on the HRSA Advancing Health Literacy in the Alabama Black Belt, which is a grant that's given specifically to municipal leaders or mayors. So that's actually a coalition of 5 small Black Belt mayors, primarily Black Belt mayors, who then are consulting with us to create health policy for their town. We also did Project United, which was a CB or community-based participatory research grant that included a research course for community members, and they actually wrote their own grants from that. You can also review federal grants. I've learned so much by reviewing some CMS grants, and also HRSA. So like you're not going to be able to necessarily, you're impacting change by doing the work for the people that are going to get funded and trying to make sure something good is funded. Hopefully you're not pushing an agenda through your own reviews. I'm not suggesting that, but I've learned so much from reviewing at what other people are doing and how to do it well. And again, we mentioned locally, you can review or write grants with United Way or your own city. Okay. Also being a source for your colleagues. So when we get all this health policy information in our heads, it's just in our head, right? And then we have it, but we need to be able to figure out how to help our colleagues with it. Or and there's always too much information for you to just have for yourself. So it's really important also then to be a resource for your colleagues to best present their work or make sure that they're talking about Medicare, Medicaid, whatever policy it is that you have in their own work. So that they can also be advanced. Or if you understand health professional shortage areas and your coworker doesn't, then you work with them on that, right? So making sure that we are having the policy represented well and accurately in yourself and your colleagues' work. This is just an example of where I worked with a coworker on making sure that we were talking about HIPAA correctly in different terms like that. Okay. Also then, an important thing to do is just represent your population and what that means at that time. So we're in the Deep South. Our populations are not understood very well by most anyone outside of here, right? And we're not the only ones like that, but we are constantly advocating just by being from here. And trying to authentically represent our research populations and the people that we're working with, our communities. Right now, for me, that looks like the Healthy Brain and Child Development Grant that we have. It's a NIH study on infant brain development, and learned an awful lot about laws and policies with mothers and substance use in our state. And we're constantly now advocating for moms on the state and national level just by doing this research. Okay. I'm gonna be done now. Because I think that I've used up all my time.
I know we have another presentation at 1 for the DEI faculty candidate, so I do want to give an opportunity for the people that have to give out. But we will be here for another like 45 minutes. So if you guys have any particular questions for Lea, and we'll leave the Zoom link on as well for everybody that's going to be virtual to be able to have some more one-on-one and small group conversations. But thank you so much.